patellar dislocation, how to frame it. So you have some questions to answer. The first would be why you had this patellar dislocation. Is that because of a sport trauma? Is that because of genetic? Yes, this is probably the reason for. But if you don't know, you will say, well, it's a bad luck, or I don't really know why this patient had a patellar dislocation. You're in the wrong way. And I hope that you will change the way. So the patellar dislocation, you need to have a good definition, and the good definition would be definitely the one who have the first time patellar dislocation. Then you will have the recurrent patellar dislocation, what we call the objective patellar dislocation, and then some specific topics, which is the habitual or the permanent patellar dislocation. The epidemiology is definitely the second cause of hemarthrosis. So anytime you have a knee trauma for the first time with a big swelling knee, you should think about patellar dislocation. So the second question is your patient will have a new patellar dislocation in the future? So you need to screen that. And you will see that you have the recurrence rate is between 15 and 44%. So you see that everybody does not need surgery. So is your patient will have a new episode? You have to look at the risk factors. Could you rate them, and are they predictive? And this is very important, and this will be given by imaging. So you know that we described it in 1987, some risk factors. They were the trochlear dysplasia, the first one, the patella alta, and the excessive TTTG. And it has been taken worldwide, and everybody are using them. And definitely more you have some risk factors, more you will redislocate your patella. So screen your patient. This is definitely the key, screen your patient. And to screen your patient, you have to start first with standard X-rays. And what to look at? You have to look at the trochlear dysplasia, you have to measure the patella alta, you have to look at the bony avulsion. Always measure and quantify what you are looking at. In the acute phase, what to look at? You have some indirect signs, and the indirect signs are the passage lesions, some loose body and intra-articular, as you can see on this image. You can have an MPFL avulsion on the patella side, and of course you will look at the trochlear dysplasia, and you will also measure the patella alta. So you could ask, after having some X-rays, you can look at the slice imaging. And the slice imaging definitely is mostly MRI, actually. And when you do this MRI, it is really typical when you have this lipohemarthrosis, as you see, okay? So, thank you. The lipohemarthrosis is absolutely pathognomonic to a patellar dislocation, because you have some blood in the knee because of the MPFL avulsion, but you have also some fat coming from the bony avulsion or the bony fracture. So you will look at the bone bruise over there, and with the bone bruise on the lateral side of the patella, and the bone bruise on the patella side. So this is typically some imaging of a first-time patellar dislocation. But look at the trochlea, okay? It's important to look at the trochlea also. And in immature patient, look at the osteochondral fracture, because sometimes you cannot see them on X-rays, but you will see them on the MRI. So you see the MPFL rupture, you see the trochlear dysplasia here. Always look at the trochlear dysplasia. It's very, very important. You see this is a flat trochlea, definitely. So the patellar lesion and the bone, you can see this small piece of fragment here, but if you have asked for on the lateral, you will see it here. But if you have asked for the MRI, you will see that it's a huge fragment, and it's a huge fragment here. So, of course, MRI is very important. and especially if you deal with a young patient. So in skeletally immature patient, the MRI is mandatory after doing the X-ray, because the X-rays underestimate the size of the osteochondral bone fragment. So you will have that, and you will see this piece of bone. This piece of bone is very impressive, and when you open the knee, you are facing that, which is major. So the patient screening for the first time patellar dislocation, if you have a low instability factors and you are dealing with children, X-rays and MRI. If you are dealing with adults, you don't really need to have an MRI immediately, okay, because you will not miss this osteochondral bone fracture. If you have high instability factors, for sure, you need to have X-rays and MRI for children, and you need to have X-rays and delayed slice imaging, because your patient could have some recurrence in the future. So it's good to rate the instability factors with the slice imaging with MRI, measuring different things. Now we move to the recurrent patellar dislocation, how to frame it. And when you have such patient, you will have the patient history with the first time that he had this patellar dislocation. You will do the clinical exam. You will see that this afternoon. And you have the imaging. And the imaging is something so important, because it will allow you to classify the patient and to make a proposal for a treatment. So the anatomical study, which was done in 1987, had two populations, control population and dislocation population. And at that time, three instability factor or risk factor were defined. The trochlear dysplasia was the most important one. You see this very big trochlear dysplasia. The second is a patella alta. And the third is an excessive TTTG with a threshold of 13 millimeter on the MRI, with a threshold of 20 millimeter if you use CT scan. And why it's important? Because it's highly related to anatomy. All the dislocations are related to anatomy. If you have a patellar dislocation population, 96% will have a trochlear dysplasia. 30% will have a patella alta. 56% will have an excessive TTTG. You can have sometimes some rotational abnormalities, mostly on the femoral side, between 24 and 40 in 50%. The tibial torsion is definitely not a statistical factor for patellar instability, and of course, you always have an MPFL rupture. You cannot dislocate your patella if you don't have an MPFL rupture, of course. So the trochlear dysplasia will be defined by some different signs on X-ray. The first thing is to check how the X-rays have been done. Always check that you have a true sagittal view, both condyle on the same line. If you don't have that, you cannot really look at the trochlear dysplasia. So the second is the axial view at 30 degrees flexion. If you have a good X-ray, you will have 1/3 for the medial facet and 2/3 for the lateral facet. It means that this X-rays has been done at 30 degrees flexion. If it's 50-50, like here, it means that it's about 45 degrees or 90 degrees flexion. And it's not good, because when you have the 30 degrees beam, you will see perfectly the upper part of your trochlea. If you have a 45 degrees X-ray, you will be a little bit lower, where the trochlea is deeper. You will miss the trochlear dysplasia, you will miss the subluxation, you will miss everything. Okay, so check the quality of your X-rays, and then you will find some different sign. What? You will find the crossing sign. You will see perfectly the bump, this proeminence, and if you can remember something from this topic today, is this bump. whenever you see that, you see it's a high-grade trochlear dysplasia, and you have to take care of it. If you have the X-rays, of course, you need to add slice imaging, because slice imaging will allow you to classify the trochlea. So you will see the shape of your trochlea, you will see the shape of the patella. And so this is the combination between X-rays and slice imaging. Very important. What do you what do you look at? You have 3 points: the medial side of your trochlea, the groove, and the lateral side. And depending on the position of these 3 points, you will be able to say that you have a concave trochlea, convex trochlea, a flat trochlea, and then you will also see the orientation of your trochlea. So the bump is mostly seen on X-rays, but it's very tough to see if you have such proeminence on the sagittal. So the MRI is good, but it's not sufficient because you cannot see very well. You cannot pick up very well the proeminence. So use both, of course. And then you end up with a classification. And the classification in 4 types, A, B, C, D, is depending on the different signs that you can have. The 2 most dangerous trochlear dysplasia, the type B and D, because in those you have this bump, the proeminence. And the proeminence, you will see that tomorrow, it's something very, very dangerous for a patella, because it will push the patella on the lateral side. The second risk factor is the patella alta. You need to use an index, and I will tell you that the Caton Deschamps index, the white one, is the best for doing surgery, because when you measure the Caton Deschamps, you know that you have a ratio, and if it's 8 millimeter too much, you distalize 8 when you do surgery, and it's very precise, and you will not have any overcorrection or undercorrection. If you use the insole salvati like that, insole salvati, when you change the position of your patellar tendon, you will not change the insole salvati index, in fact. So it's not so useful. The most surgical index is a Caton Deschamps. But also, it's very important to look at the engagement of your patella in the trochlea. And you will see that the patellar tendon length is more than 52 millimeter in patella alta. You will also look at the relationship between the patella and the trochlea. And then you will be able to measure the sagittal engagement index. This is a variation of the Bitter patellotrochlear index described by Bitter. We change a little bit the way to measure it, because when you have a subluxation, you cannot use a Bitter index. So this is a superimposition between the patella and the trochlea, and you see exactly how the patella is engaged in front of the trochlea. Very important, and you will see that in the indication later. And then the tibial tuberosity, the TTTG, which is the malalignment evaluation, is the third instability factor. It's very important to know that this an excessive TTTG is never a factor alone. Trochlear dysplasia could be alone. Patella alta could be alone. Excessive TTTG, no. It's always combined to trochlear dysplasia or a patella alta, okay? So you measure that by superimposing 2 cuts, one from the trochlea, one from the tibial tuberosity. So you need to have some tools to measure it. It's very important. And it would be abnormal if it's more than 20 millimeter on the CT scan and more than 13 millimeter on MRI. So this is a little bit different values, and you need to know that the thresholds between CT scan and MRI are a little bit different. But you can do both, so you can use MRI or CT. And for example, more and more I'm using MRI, and I think that I see more things on MRI than on CT now, okay? So at the end, what? At the end, you have some risk factors. You have the trochlear dysplasia, you have the patella alta, you have the excessive TTTG, you have the tilt, you quantify the tilt, and the secondary factor, which are the rotational things of the on the femoral side. And if you know them, you will be able to correct them if you need to do surgery, and you will win the gold medal of the patellofemoral joint. Thank you so much for your attention. Okay, I continue for to my next presentation. So just I have to open it. Oula. It's very tough to read, huh? I unplug that, if you don't mind. Now we will speak about MPFL, okay? And you have seen the way to screen your patient, and now we will start to discuss about how to treat your patient. And for sure, this would be very important. And we will start by looking at the MPFL and the way to treat your the soft tissue part. First of all, you need to know a little bit more about the role of the soft tissues and the MPFL according to the bony abnormalities, of course. So first of all, we know that when you have a patellar instability, sometimes you have a VMO dysplasia. And the VMO dysplasia means that you have no oblique fibers like that, and you have only one part of the VMO. So it's a dysplastic VMO for sure. But the medial complex is very important, and when we talk about the medial complex, we're talking about the MPFL, of course. And the MPFL has this part, the biggest part of this medial complex is MPFL, but you have also the MPTL and the MPML. So the medial side would be described as these structures, and you have three layers coming on the medial condyle, which is the retinaculum, the MPFL, and the synovium. Okay, and that's very important because when you will address the MPFL, you have to find the second layer. So when you look to this beautiful description of the medial side, you will see the adductor magnus tendon, you will see the medial, the epicondyle, the MCL, and the medial ligament. So if you look at the bone, of course, you will find this area, and the MPFL is something around here. But it's very tough to find it with your finger. And when you will do surgery, if you try to find it with your finger, you think that you are in the good spot, but the spot is not so precise. And probably it's not probably, it's mandatory to use fluoroscopy. So the fluoroscopy is the key factor for doing an MPFL and for positioning well your MPFL. And you have to use this point, which was described by Schottler and Amis, and it's the anatomic placement of your MPFL, and that's very important. So what does the MPFL? It is definitely the primary instrument for the lateral displacement of the patella, okay? So if you don't have it, you can push the patella on the lateral side. But it's very important that if you have a well-centered patella with a normal anatomy, the MPFL is not really necessary. And when you do a total knee arthroplasty, you test the patellar tracking with no MPFL, no vastus medialis, and it works well because the anatomy is perfect. So the MPFL is just what we say a check rein. It retains the patella if you have a load applied on the middle side of your patella. It might be isometric or it might be non-isometric. And I have to say that probably it's not really isometric. And I would say that the MPFL is mostly tight in extension, and the real role of the MPFL is to retain the patella in extension. And then when you flex the knee, it becomes a little bit loose. But it's not a problem because the patella is engaged in the trochlear, so the patella is definitely very stable at that time. So the biomechanic, as you have seen, is that it's nearly isometric between 0 and 70 degrees flexion. And all those studies, all those fantastic studies are done in the cadaver lab with normal knees, because when you go to the cadaver lab, most of the time you don't have trochlear dysplasia. And most of the people who did this, who have done those surgeries, never looked to the trochlear dysplasia and never know what is trochlear dysplasia. So the MPFL technique, what it is? It has been described in 1992 by a Brazilian guy. His name is Elera Gomez, is this guy. This is Elizabeth Arendt and myself. And definitely it's easy to do. Small scars comparing to the old-fashioned TT osteotomies, very sexy and very attractive, of course, but everything which is sexy and attractive is dangerous, because it's dangerous. Yes, I can tell you that it's dangerous. So it's dangerous because you can say, well, I will do an MPFL to everybody, and it will work. But sometimes if you miss the anatomical abnormalities, it will not be really good. So when you do an MPFL, you can use a soft tissue MPFL, which goes in the MCL, or this technique is it would be on the soft tissue procedure. My preferred technique, you go around the third adductor. It's pretty good because when you do that, you don't need a fluoroscopy, of course. And it's a soft tissue attachment, so you cannot over tense your MPFL, because the biggest issue with the MPFL is when you over tight your MPFL. And then you can have the bony procedures with some anchors on the patella side, with the tunnel on the femoral side, and some techniques describe a drill tunnel in the patella side. Definitely, I really think that it's a bad option to do some tunnels in the patella, because you make your patella fragile, and then you can end up with this, and this is really painful when you have a patellar instability. So you move to a very bad MPFL with a fracture. So you see, this is the worst surgeon in the world who did this surgery, or the guy who knows nothing about the patellofemoral joint. So the MPFL reconstruction or plasty has some principle, some bony tunnels on the patella side. Personally, I don't like to put any anchors or hardware material on the patella side, and I use a interference screw on the anatomic position. This is the way I'm doing, and first I test the ML displacement of your patella, and I would say that this is a quadrant test. Then you see that if you push the patella on the lateral side, you dislocate it, of course, and then you harvest the gracilis. We take the gracilis. If the gracilis is okay, sometimes your gracilis could be very thin, and if your gracilis is too thin, you take the SMIT. It's not a huge issue or problem. You stitch your graft, then you detach it from the femur and you size it. So you do approximative sizing, and then you expose the medial part of your patella. Okay. Then with the 4.5 millimeter drill, you drill on the top of the patella on the cortical side, because the cortical side is very strong. You never have any fracture. I don't like to go on the medial side of the patella because I had some fractures. And so I moved to this technique a long time ago. Then I can pass my Semite or my gracilis in those tunnels, and I find the second layer. And it's very easy because you go just below the VMO, and with the tip of your knife, you will find when the color is changing, you find the synovium, and this is the exact placement. Then you will reach the femoral point, and so you do the scar incision, and then you have to use the fluoroscopy. If you don't use the fluoroscopy, you will be always wrong. So I always use the fluoroscopy, and when you use the fluoroscopy, be careful to have the two condyles on the same line, exactly the same way as you do on X-ray. Okay, so the key wire has been positioned under X-rays. We go through, of course. Then we drill a bone tunnel, 6 millimeter usually, and we fix it with a screw. You can do that with isometry. So I do that for the video. I can do that for my visitors in my OR, but frankly, it doesn't work so much. The best is to have the fluoroscopy. Okay, and when you have the fluoroscopy, no way it works so well, of course. And as you are in the anatomic position, no problem. You don't have to overtense your MPFL. So it goes in the patella side, okay? Then it passes in the medial part of your knee in the second layer, okay? It goes all the way through, okay? Then I pass this, and then I will overtense my MPFL. And I put a cocker on the other side, okay? And I test. And then I cycle the knee. And then the length is taken automatically, okay? So when I did my cycling, I keep this position. And I would say, you see, this is the MPFL. The MPFL, a good MPFL is a little bit loose. It shouldn't retain your patella too much, because if it retains too much, it means that you are overtense. And then we close the synovium. So the patella and the trochlear morphology are really important compared to the MPFL, because on this patient, your MPFL would be okay. On this one, you will have an MPFL, of course, but a long MPFL. And on this one, the MPFL is even longer. So the native MPFL is definitely adapted to the position of your trochlea. The same for the patella alta, okay? And when you have such patella alta, or this one, you see the level of your patella. Your MPFL definitely will not have the same length from the beginning. So the attachment site you have seen are very important, and the anatomic insertion will never change, but the size of your MPFL will change depending on the anatomy, of course. So this is something important about the biomechanics. If you have some anatomical abnormalities like that, patella alta or patellar dislocation, what about your MPFL? What about the size of your MPFL? Okay, so if you say, I will do an MPFL to everybody, and I will not correct my patella alta, your MPFL will never work, okay? It will never work because the biomechanic is not good. So if you use the MPFL on this permanent patellar dislocation, if you do not correct this trochlear dysplasia, it will never work for sure. So we know that this is a technique, and this is definitely not the universal solution for patellar instability. And this is something very, very important to remember after this talk. The MPFL definitely works well if the patella is facing the trochlea. But if you have no patella in front of your trochlea, if you have subluxation like that, if you do an MPFL, you have to overtense your MPFL. You will get some fatigue rupture, some pain, some tunnel widening, some recurrence, and some stiffness. So in all those cases, you need to correct first the anatomical abnormalities before doing anything else. The MPFL is done at the end. So what do we learn from the literature is definitely that you need to correct the anatomical abnormalities to decrease the MPFL constraint. If not, the graft will be overloaded for sure, and the risk of failure will increase. Fluoroscopy positioning, very important. No over tensioning, as I said, because you will get a flexion limitation, or you will have some pain. And you always say that, wow, the MPFL has been wrongly positioned. Okay, so use the fluoroscopy, no problem. You will be always very good. Use the fluoroscopy. But I mean that if you do a right positioning, but you do not change the position of your patella, in case of trochlear dysplasia, for example, your MPFL will be wrong. It's exactly the same as if it was not well positioned. So that's very important to change those factors, trochlear dysplasia and patella alta. Just I will go back to this. So what do we recommend? It's a low-grade trochlear dysplasia, type A, no patella alta, no excessive TTG, no excessive tilt. This is a good indication for an isolated MPFL for sure. And I always use that. So personally, I have very few indications of isolated MPFL. And most of the time, I always find a very good reason to do a mild distalization, a mild medialization, because definitely most of the time you have that. So this is exactly what I've shown. So for sure, remember that MPFL has a pretty high rate of failure, and this article is very interesting because it says, well, be careful, don't do an MPFL to everybody because you will face 26% of failure. So that's something very important. So you see that if you have a high-grade trochlear dysplasia, B, C, D, if you have a patella alta, if you have an excessive TTG, correct those factors, and then you do your MPFL. So MPFL is mostly an associated procedure than an isolated procedure in my hand. Okay. So remember that MPFL rupture is a consequence of the patellar dislocation. This is not the reason for the patellar instability, and the MPFL reconstruction is mandatory to any patellofemoral surgery, isolated or associated, depending on the amount of anatomical abnormalities. Merci beaucoup.